We are sorry about that. We are so happy that you joined the course for leveraging primary healthcare for COVID-19 response insights from the Ethiopian Health Extension Program. We have invited experts from WHO Africa Regional Office, which Dr. Micah will be introducing later on. My name is Antana. I'm the Director of Programs at the International Institute for Primary Healthcare. I'll be moderating this session with Dr. Micah Schleif, who is the Assistant Scientist at the Department of International Health at Johns Hopkins University. So today we will be covering and speaking on the topic, adaptation of COVID-19 guideline, implication for primary healthcare focus, and attainment of universal health coverage. So we will invite colleagues from here, Tersit and Brooke, to talk about any housekeeping issues and updates. And then I will invite Dr. Micah Schleif to introduce Dr. Humphrey, and we will have a good amount of time for discussion and question. So I'll pass it to Micah to proceed.
All right. Thank you so much, Dr. Antana and colleagues at the Institute. It's great to have you all with us. And I think we have one poll that we wanted to launch quickly. We're just curious which continent all of our participants are joining from today. So if you all would be able to just quickly choose the best option for where you are coming from, that would be wonderful. We just want to have a general sense of who's in our audience today, and we're very excited to have you all and excited for a great discussion. So seeing the results rolling in here very quickly, and just give that one more moment, and then we'll proceed on to the next. While we're doing that, I'm going to stop sharing screen so that Humphrey can put his slides up. And I'm going to go ahead and end the poll. We've got a good response rate here, and it looks like very clearly we've got a strong showing from the African region, which is very exciting. So great to have all of you, and also seeing folks joining from North America and Southeast Asia. So thank you all for that. And I see that Humphrey's getting his slides up. So we are very excited for this presentation today. Dr. Humphrey Karamaji is working with the WHO African Regional Office and travels extensively across the region. He is senior advisor, and he's part of the health systems development department for WHO, and has really been focusing his work on primary health care and universal health coverage. And so he's bringing a perspective both on some of those broader initiatives that have been going on for several years now, and then also specifically the impact and the sort of efforts around how COVID-19 has been addressed across the region, and being able to sort of bring in that PHC focus and continue to think towards universal health coverage. So Humphrey, thank you for joining us today. I'm going to pass over to you to say hi and go ahead and share your presentation, which hopefully will launch a wonderful discussion with the participants. So welcome to you, and over to you.
Okay, thank you, and good afternoon, good morning, good evening, wherever you are coming from. We feel quite happy to join this discussion. I think when we were invited to come and have a discussion with the team about COVID-19 and PHC focus, particularly in the context of attaining UHC, it was something which we naturally felt, okay, this is quite an important subject to discuss with people, particularly people who are at the front line of health service provision. I think this is the kind of challenge which many of you are grappling with. How do we respond to the COVID-19 pandemic without, again, forgetting that there are many other problems that the country is struggling with. The fact that you're struggling with COVID-19 doesn't mean your diarrheal diseases or malaria take a pause. So it is important that whatever we are doing as we are responding, we keep that frame of mind in mind. We keep that frame of mind in the picture. And so I'll go over a few slides which are more aimed at initiating a discussion. I'll try and make them a bit more on the technical side, so that we can understand why certain things are being done or are happening the way they are being done or they are happening. And hopefully that will then help us to focus on a discussion that looks at how we move forward. How do we make sure that we do not lose sight of the PHC focus, the need to attain UHC, but at the same time, we're able to respond adequately to this very huge challenge that the countries are facing. So as a starting point, we wanted to emphasize the fact that whatever we're doing in countries in health is fluid. So we have been reforming systems. When we are talking right now about UHC and the SDGs, it comes from a long history of doing a number of things that are important in terms of adapting to the health priorities at a particular point in time. If you look at the pre-1950s in the African region, what we generally look at as the colonial period, most of our health systems were designed around a very medical approach with a focus on treating visible diseases, largely for the colonial system, the colonialists plus the people working with them. And this was really a cost recovery kind of system that was primarily built around the individual financing. So you have a problem, you would go and get the services. This kind of system was very low impact, low cost for the entire system, but high cost for the individuals, and of course, very inequitable. When many of our countries in the region got their independence, they tried to redress this particular problem. And really the focus at the time was, how do we expand hospital services? Because a lot of healthcare was really hospital-centric. We need to build hospitals so that people can be healthy. And you see in many countries through the immediate post-colonial period, there was a lot of establishment of hospitals all around the countries. And these were treating diseases, not just for the administration or the people in charge, but also now providing services for the wider populations. And also we had the expansion of the PhDs, the public health technicians, who are moving around in the homes, enforcing environmental health and environmental health messages and so on. And this was an era where we had significant improvements in public financing. A lot of financing for health was publicly sourced. Governments were at that time able to afford. Many countries were running fairly good budgets, but of course this system quickly bankrupted the countries. The disease burden was still quite high, so it was really low impact. It was very costly and very inequitable. You had to stay near a hospital to be able to benefit from that. And really that's what drove us into the Alma Ata and the initial PHC iteration. And here again, the focus was on, can we focus on those basic services which most people require for their health and well-being. This was, I think all of you are quite aware of the 1978 Alma Ata Declaration, very good, very aspirational kind of thinking. But once that was passed, it was very quickly realized that, well, it is almost impossible to achieve. And we moved into the selective PHC approach, whereby we are focusing on a small set of conditions, but what we're calling high impact interventions. In the 80s, we're talking about GOBIF, growth, that is growth monitoring, oral rehydration salts, breastfeeding, and so immunization, and so on. And this focus on a small set of interventions really took us straight into the MDG period, where again, we're focusing on HIV, TB, malaria, maternal health, child health. So still the same concept, but the group of conditions had evolved to align to what was the problem at the time. And again, we had quite a high impact, particularly on those interventions that were being addressed. The costs were going higher and higher because the need or the cost of reaching more and more people with adequate interventions kept rising. So the costs, while they started quite low earlier on in the Alma Ata, post-Alma Ata, the costs kept going up over time. And right now, you can see the huge amounts of money that are spent, for example, in managing HIV or malaria and so on. And I think that led us right into what we are looking at now as the UHC phase, which is we are reverting back to what was the comprehensive PHC approach, where services are built around the person as opposed to diseases. And the whole idea is, how do we ensure that people are able to access the services that they need for their health and well-being, irrespective of who they are? So not focusing on particular diseases, not focusing on particular age groups, but even if we have a 70-year-old person sitting somewhere down in Aksum, in Ethiopia, that person still is able to get the interventions that they need for their health and well-being. And really, I think the impact and the costs are still being understood better. But I think we're now moving the discussion away from cost to value. Is this an investment that gives very good value? So when we are talking about moving towards the COVID situation, we are really talking of a system that has undergone quite a lot of evolution. It's more or less designed to respond to the health needs of the large proportion of the population. Many countries are still in the process of aligning their systems towards a UHC, away from an MDG kind of focus. And UHC really encapsulates that vision quite well. You're talking about a system that is trying to make sure that there are more services available for people and across all the different age groups. These services are reaching the hard to reach people. So wherever you are in the country, being far or near from a facility should not be the decider whether you're able to get the services, but also managing the financial risk associated with the access and use of essential services. So really, that's in a broad in a broad way of looking at things. That is what COVID found us at. It found us in a frame of mind that most countries were trying to push and attain universal health coverage and other health-related SDG goals if they were to attain the health and well-being that their populations deserved. And the countries were really at different points in time, different points with regard to UHC. So this graph just shows the two UHC indicators. One is about service coverage, which is on the y-axis, and then on the x-axis you have the indicator to do with household spending on health, looking at 10% of household spending. And you see the countries in Africa at various points within this. What we're interested in is having the countries in the top left quadrant. That means they have high service coverage and low proportion of household spending. And you see the countries that are there, right from Angola, Seychelles, Cape Verde, Namibia, a mix of different countries, not all high income, because we have Zimbabwe, Zambia, Ghana also within that group of countries there that are doing quite well. They are having very low expenditures, very low catastrophic expenditure, but fairly high above the regional median levels of service coverage. So mixed picture, a lot of work that needed to be done in the region. You can see where your respective countries are. Ethiopia is just at the lower left, in the lower left quadrant. I'm sure you found it by now. But basically, there was a lot of work that was needed, that needed to be done in each of the countries. And this was what we're focusing on. When we're trying to see what are the key changes that we need to focus on if we are to move the agenda away from what was a selective PHC approach to a more comprehensive PHC approach, there are a lot of changes that were agreed are very important. Many of us have grown up in health systems that focus on promoting interventions that are targeted around specific diseases. So I talk about HIV, I'll talk about neglected tropical disease and so on. But then now we are talking about how do we have interventions that are targeted at an individual. So it is not the disease that is the focus. I'm looking and saying, this is an adolescent, 14-year-old girl, what are the health needs? What are the interventions that a 14-year-old girl needs in Ethiopia for her to be able to safely navigate through the adolescence period to the next stage of her life? And the system then is trying to provide that set of interventions for that person. Also, we have, I think this is something that we've been talking quite strongly about, that we need to have a prevention and promotion focus, because that is the most cost-effective, those are the most cost-effective investments. But right now, with the UHC and the new comprehensive PHC approach, the focus is on how do we balance the different public health functions. So we are not just talking about we should only invest in preventive, but then what level of investment is needed across the different public health functions. And I think COVID has been quite a very good example of the danger of not investing across the public health functions, because in the absence of our clinical services, we are not able to provide the oxygen and the other support that people who are sick with COVID require. And if a country had not invested in that, then it would be in trouble. If we are not investing in rehabilitative services, we will not be able to talk about long COVID and look at how to support people after they've recovered from the acute phase and so on. So really the discussion moving away from saying we should focus on prevention and promotion, but to a discussion about how do we balance investments across all these public health functions so that people can get the services and the interventions that they require. Then also the equity focus, we really were focusing a lot on rural populations and the poor people, but now we are recognizing that equity is quite a very complex issue. There are very many people who are left behind for various reasons. There are gender issues, cultural issues, in addition to vulnerabilities due to poverty and so on. But even within urban areas, I think many of us will agree that there are quite a lot of people left behind in urban areas. If you look at the urban slums and so on. So we're trying to have a more comprehensive look at equity, not just looking at the rural poor, but looking at what are these different social, cultural, gender gaps and so on, and how does the system put in place ways to address this. Also, related to the earlier points, the service delivery approach, I think you do recall a lot of the PHC approach was based on establishing primary care facilities, health centers and so on, which are then coordinated by a primary hospital. But now I think we are now looking and saying, how do we map the roles of the different levels of the system and provide these services? So it's not about saying we're only putting money in primary care facilities, but what money should we be putting in the tertiary hospitals or in the secondary hospitals, in the primary hospitals and at the primary care level? Again, similar as with the public health functions, it's not about pitting one against another. It's about getting the investment right, the investment mix right. Also, pre-COVID, there was quite a focus on identifying a basic set of services. I think many of you, even in Ethiopia, there was quite a lot of talk about basic packages of services. And I think I do not believe that anyone wants to work in a system or to exist in a system which says the best I can do for you is basic services. Now the discussion has moved away from basic towards what we're calling essential services. So what are those services which are essential for your health and well-being? And that then shifts the discussion a bit more, and the investment is focused on building the capacity towards being able to provide that set of services that are essential, irrespective of the age at which you are. As opposed to the past where the system says, this is what I can afford and this is what I'm going to provide. And then again, yeah, plans are based on budgets with the resource mobilization externalized, which is what we're used to. But now we are looking at planning based on needs with a strong emphasis on public financing because we're trying to internalize the resource mobilization. So many people really struggle with this, and many times they're asking what is different. What did PHC bring? The renewed PHC effort. What is it bringing? What is different about it that was not there in the past? And I think these are a number of issues where you can clearly see that the thinking and the approach is very different from what we had in the past. So what did COVID do? COVID-19, just like in the rest of the world, was a completely new health challenge in Africa. We have been having influenza outbreaks. We've been having a number of outbreaks, Ebola and so on. But this was a completely new challenge which stresses the system at all its levels and at almost at the same time. And really countries were not really prepared for this at all. It led to the need for additional interventions on an already overstretched system. So many of the systems in our countries were already working almost flat out. And we then have this additional set of interventions. There was quite a lot of health promotion work going on, which basically dominated the airwaves in all countries. Now we are talking about the vaccine rollout. Vaccines are very complicated products to handle and manage. And so that is taking up a lot of resources and time. But even the people who are falling ill, there was a lot of emergency care, high dependency units, ICUs being required. Again, these are areas which we had not traditionally invested in our health system. So many of our systems in Africa were really caught flat-footed, especially when it came to the emergency care services. But the effect of COVID is not just due to the COVID-19 pandemic itself on the system, but even the disruption in the provision of other essential services. This we have data now which is showing that this disruption is real. It was not just something which was imagined. And the disruptions are persisting even when countries have opened up their economies. So we are seeing reductions in utilization of other essential services, even when there are no lockdowns. People are not coming to the facilities, or facilities are not providing services the way they were providing them before. And this is not associated with the state of lockdowns or with the burden of COVID-19 in a particular country. We are seeing lockdowns in countries like Ethiopia, which were hit very hard by COVID. Also lockdowns in countries like Burundi and others, which were not as hit by COVID-19. And also we are seeing that the disruptions in essential services are happening across all the programs. So in the beginning, the focus was largely on what we call the specialist outpatient services. So special clinics, antenatal, and so on were the ones which initially were having the disruptions in services. But now we are seeing the disruptions across all services. in different countries. And also with previous outbreaks, for example, with Ebola, the disruptions were largely for inpatient services. But now I think we are seeing a much broader range of disruption of essential services as compared to previous shocks, which were focused on particular services. And also the disruptions in the essential service provision are driven not just by demand or supply, but by both demand and supply side factors. On the demand side, the communities still have certain perceptions of fears about COVID, about the vaccines, about what is being planned, but also a number of communities have been affected financially as a result of lockdowns or disruptions in their businesses. And on the supply side, there are the issues of PPEs, for example, for health workers, very important issue, which is affecting health worker motivation. How motivated are health workers to go out and provide their routine services when they do not feel they are well protected, and a number of other issues. So quite a lot of disruptions to essential services. So it's not just about the COVID cases and COVID deaths, but also other services are being affected. Also, we're seeing diverting of funding and oversight focus. So a lot of ministries of health, a lot of our health stewards are largely focusing on COVID-19 response activities, which is of course to the detriment of the other services. But I think, again, COVID-19 is not all doom and gloom. We have seen a higher profile of health issues in countries at the political and global level. You're having presidents, you're having parliaments, you're having cabinets spending a lot of time discussing health issues and how to invest in health. There's also this issue around the impact of other communicable conditions. For example, upper respiratory tract infections, diarrheal disease, especially among the children, due to school closures and a lot of the other interventions. There is some evidence in some countries that these conditions have reduced in terms of their severity in countries. But again, that information is still being brought together. And also, we've seen more funding coming for health than has come in the past. So yes, COVID-19 has done a lot of bad things, but there are also some opportunities that we need to take advantage of if we are to really make the best out of what is a very difficult situation. The COVID-19 is one of many shocks that Africa is facing. On the right here, we've just shown 1 week, 29th March to 4th April, the situation with regard to different shocks. In the Africa region, we had 116 events going on, different shocks of different kinds, of which 103 were outbreaks and 13 were humanitarian crises. This does not even include the political shocks or the economic shocks that our systems are facing. So the point here, which is most important, is that our countries grapple with multiple shocks of varying intensity at any point in time. COVID-19 implications on our Phc approach needs to be viewed in this context, that the countries are every day facing multiple threats. COVID-19 is one of the acute threats. And at the bottom, we've classified the different kinds of threats that the systems in Africa are constantly facing. There are the disease threats, such as COVID-19, which is an acute threat, or Ebola virus disease. But you also have some chronic threats which are constantly applying stress to the health system in countries, such as cholera and a few other conditions, yellow fever, etc. You also have a lot of environmental shocks. I think these are quite common within the region, floods and so on, and also drought being more chronic threats, which are also threatening the health services within the countries. Economic shocks are also quite common within the region. Sudden changes in health funding, We've seen this in a number of countries, in a number of situations where suddenly what was being funded, what was being provided is no longer able to be provided. And then also political shocks. I think in Ethiopia, you've been struggling with what was happening in the country, in Central African Republic, in many other countries. There is no country which is protected from political or security shocks. This can happen anytime and at any point in a particular country, and this then disrupts the service provision capacity. So COVID-19 is coming into this kind of situation. And so when we're talking of a PHC approach to respond to COVID-19, we need to contextualize the PHC approach into a situation whereby we're saying that there are many threats which are being faced. Some threats are known, some are not known. We did not know about COVID-19 1.5 years ago, but suddenly it's what we talk about every day. And we expect to have more threats coming forward in the future. So when we are talking about how then do we respond to something like COVID-19 from a health system point of view, we are talking more about how do we make our health systems more resilient. And that's really the emphasis that we're trying to place. How do we make our systems resilient so that they are able to react appropriately to a shock event that hits them with? And really resilience, we are talking about the ability to anticipate, absorb, adapt, and transform itself when facing a shock event. And the whole aim of saying we need a resilient system is to be able to minimize or prevent the current or future disruptions to essential services provision. So a shock event will disrupt what services are thought to be essential in a country. And by making the system resilient, we are trying to minimize that disruption. One of the ways that we minimize the disruption is by snuffing out the shock event as fast as possible. But another way is also to build the system's capacity to operate beyond its existing capacity. So this is, when we talk resilience, we are talking of a function that is needed at all the levels of the system. So it's not just about the health facilities, it's not just about the national level, even the community. We are talking about community resilience. How do we build the ability to anticipate threats, to absorb those threats when they happen, to adapt and transform as a result of the threats, so that in the future, when it's faced with a similar threat, it is not threatened, it's not hit as much as it was hit the first time. And we try to think of resilience in two ways. One is what we call the inherent resilience that a system needs to have. And the second is what we call targeted resilience. And really the way we distinguish these two is the targeted resilience is resilience against known threats. So if I know that Ethiopia is prone or is at risk from COVID-19, then we can build specific elements of the system that will help Ethiopia to resist the COVID-19 if and when it happens. But the inherent resilience is built irrespective of the type of threats that the system is facing. So if we had been working on inherent resilience, for example, before COVID-19 came, when COVID-19 came, it would not have as much an impact, even if it was something which we did not know about. And there are a number of activities or actions that are important to build these two kinds of resilience. For the targeted resilience, we have the emergency preparedness activities. There are 13 capacities. I think those, we know them quite well. There are 13 capacities which need to be built. And you see those different capacities are targeting particular aspects of resilience. So when we are trying to build the emergency preparedness and response capacity, really we are trying to build resilience against particular threats which we are aware of. But for the inherent resilience, the capacities again are 5. System awareness, the ability of the system to understand and know its strengths and vulnerabilities, the diversity in the system, its ability to provide a wide range of services, self-regulation, the ability to make decisions, particularly at the front line, the mobilization capacity, are you able to pull resources together, and transformation capacity. And a lot of these capacities, we need to be looking at them at the community, at the health facility, and at the national level. So not just saying that then at the national level we can make decisions, but then somebody at the front line, I am in a facility which is just bordering Congo, and I've got a sudden case of bleeding, excessive bleeding through the mouth, through the nose, through all the orifices. Am I able to recognize that, which is the diversity? Do I have that range of experience to be able to pick that up? Can I make the decisions that I need to make to be able to manage that problem at that point in time? Am I able to mobilize the resources, financial or otherwise, that can help me to respond to that? And am I able to pick up and learn lessons so that other people can see what I'm doing and learn how to respond to that? So it's not just something that we are looking at the national level. The inherent resilience is more important the lower you go into the system. From at the facility level, very important. At the community, extremely important. So really we look at systems needing to have resilience at two levels, or in two different kinds of resilience, targeted and inherent resilience, as being very important for the system to be able to respond adequately to a threat like what we are struggling with currently. But what does this mean in practice? We have looked at data across these two different elements of resilience and come up with what we're calling a resilience index. The map in the middle shows what is being looked at as the overall resilience on a country by country basis. So looking at a score from 0 to 100, where do different countries lie within the region? And you see a different picture across the different countries. And then to the left, we have the inherent resilience. So countries whose systems are inherently resilient, they can respond appropriately to any kind of threat, whether it's known or not known. And then to the right, we have the emergency preparedness and response capacity, which is largely your SPA state party annual reporting data, which is showing this is our emergency preparedness and response capacity. So you can see there are quite a lot of differences across the countries. There are some countries which are very good with inherent resilience, others are very good with emergency preparedness, and the converse is also true. I think this helps us a lot in terms of being able to know how to focus. If we're talking about improving the resilience in the countries as a way to ensure that we've integrated the COVID-19 kind of risks into whatever is going on in the country, I think this helps us quite well in terms of knowing where we need to place emphasis. Overall, we see resilience is quite low in the region. Inherent resilience is fairly lower as compared to the targeted resilience. And then you see the different countries. It is high in South Africa and a few other countries, but in Togo, Chad, and so on, we're having very low resilience of the system. So those systems would collapse quite fast when they are faced with threats. But now, if we understand and say resilience is an important capacity, how do we then put that into the wider discussion around how our health systems need to be developed in the context of PHC and UHC attainment? And some of you would have seen this before, but basically it's a logical approach to what is going on in the countries, from the inputs, what kind of investments are needed, which is at the lower level of the figure, and then the outputs, which is basically saying, if my system is functioning, what kind of capacities should it be able to exhibit? And then the outcome level, which is UHC and all the other areas, health security and so on, and then the impact, which is the SDG 3 target of good health and well-being. And we see that we need to think about integrating the COVID-19 actions across all these different levels. At the investment level, we need to be thinking about what are those kind of investments that we need to make to be able to build the resilience in a system. So you're looking at investments across the health workforce, across health products, across infrastructure, across the different elements of the system, and even in the context, what are those investments that you need to make that will build resilience? And I'll share some examples on the next slide. But then the issue around resilience then needs to be looked at as one of the capacities of a functioning system. And so we put it at the output level, whereby together, if a system is said to be functioning effectively, that means it is a system that is able to ensure better access to services. Those services are of an appropriate level of quality. And they are services which are demanded by the population, and the system is able to provide those services all the time, even when there's a shock or no shock. So in that way, then we are looking and saying that, okay, if we are to think about the COVID-19 pandemic and how we're able to respond to it and how the response actions fit into the Phc approach that we are implementing, we are then saying that, okay, if we are to assess the system in Ethiopia or in Mozambique or in any country, resilience needs to be one of the 4 elements that we assess that system's functioning from. And if the system is resilient, then we say, yes, at least on this area, the system is functioning, but maybe it's not functioning in other areas. So basically, we are looking at integrating these concepts that are very important in the COVID-19 response into all the elements of the logical approach for the health sector, from the investments to the outputs to the outcomes, all contributing to a standard impact. I think I will not go into this, but this, you can look at it later. You'll have the presentation. It just gives examples of a number of interventions that can be carried out that will help to improve the resilience of a health system across its different building blocks. But just to wrap up now, I know I've taken a bit long. Just to wrap up, the key messages from this presentation: our systems, our sectors are in constant flux. They're always changing to align with current needs. Right now, COVID-19 is the current need that our systems need to adapt to, and the systems need to pick up the lessons from the history in terms of how we're able to integrate the lessons that are coming out of COVID into the way that the systems are working. COVID-19 has enhanced the need for us to integrate issues of health security and resilience thinking into our systems development initiatives. And we really need to look at resilience as a capacity of a functioning system. So it is not a by the way, it's not something which you say when there's no COVID, then we don't talk about resilience. It should be one of the measures that we are using to say this system is functioning. Why? Because it is resilient. But resilience also has different facets. We have looked at 2 facets of resilience: inherent and targeted resilience, and these 2 facets need to be built within the country. There are specific interventions which exist to enhance the Phc approach that is needed to be able to design systems that are resilient and are able to absorb and respond appropriately to health threats like COVID. I think I will end here for now. Again, the presentation, you'll have a few references which you can look at later on. But I think the message is quite clear that we need to change in terms of what we are doing, and we can change because we have all the tools that are needed to allow us to change and adapt to the threats that we are facing. So thank you for now. I think that is what we had. I hope it is adequate to initiate a discussion.
Thank you, Dr. Humphrey Karamaji, for the thorough and nice presentation. We have a couple of questions from the participants. We can proceed for the discussion session. I think we have 14 minutes before we conclude our session for the discussion. So, Micah, do you have?
Sure. Yeah. Thank you so much, Humphrey. That was really informative and very exciting. So maybe we could start off. We got an initial question from a participant that was really about, how country responses to COVID have strengthened primary healthcare systems. And I think you mentioned some general sort of principles and approaches for that, Humphrey, but I don't know if you have any specific examples from across the region of, where, some of these responses have really been kind of exemplary in being able to respond to this new crisis and also be able to, continue to contribute to primary healthcare. So just wanted to ask you about that first, and then we'll move on to further questions.
Okay, I think that's quite country specific. In different countries, you've had different areas of focus, and also in the initial period, at least, many of the countries were really responding to COVID in a very vertical way. But then there's one or two things that are consistent across countries. First of all, many countries are saying that, well, we should have invested a bit more in emergency services, in emergency care, and which really helps us a lot because we had always been saying that when you're talking of a primary health care approach, it does not mean you do not invest in your hospitals because you're going to have a crisis which will require this kind of hospital services. But now I think that is something which almost all countries are quite clear about, that we need to at least invest in the primary hospitals, if that's all we can invest in. But then we need to integrate the hospital care into the primary healthcare approach within the country. Also related to that has been, which hasn't taken off quite well, but I think it's quite clear from COVID, is the need to place more emphasis on the NCDs, non-communicable conditions. I think this is one of the areas which has not taken off as well as it really should, because your risk of getting symptomatic disease is increased significantly when you possess a number of NCDs, obesity, hypertension, diabetes, and so on. And so if we're able to, and we ran some analysis at the beginning, and it was quite clear that countries which had the lower burden of these non-communicable conditions were having much lower mortality as compared to countries which were having higher burdens. And so I think this was just a golden opportunity in our view for the NCD agenda to be addressed, because you actually have the live evidence on the table that if you're addressing your non-communicable conditions, you're not only stopping burden due to those non-communicable diseases, you're even influencing communicable disease like COVID. So I think those would be two areas which I would say have a direct effect on what the system work is doing. The non-communicable focus, very important, but also the need to have investments in the hospital sector as part of your PHC approach. Over.
Thank you very much, Dr. Humphrey. We also received a question with regards to the Ethiopian primary healthcare system. The question is, what shaped the delivery of primary healthcare in Ethiopia? Ethiopia had, passed through different eras of the evolution of the primary healthcare in Ethiopia. Dates back to the basic health service and then followed by the primary healthcare period. But one of the critical things that happened in 1993 was health policy emphasized democratization and decentralization of health services to reach out to the majority of Ethiopians who don't have access to health service. Following that, we had different programs. Then in the year 2002, we had the introduction of the health extension workers who were delivering house to house the different healthcare package. So that really influenced how Ethiopia has improved in different indicators with regard to the MDGs. And the health extension program is one of the well-recognized and flagship program of the Ethiopia, which was able to make significant improvement in the lives of the majority of rural population. Following that, we also have designed the urban health extension program, which we had made some progress. But for most part, what we can say is, one, the health policy emphasized for democratization and decentralization of health services to the vast majority of the Ethiopian population. The other one is the deployment of health extension workers to the different villages across the country and in most hard to reach areas where there are no services in the past. So the government commitment would be much appreciated in putting the health extension workers on its payroll and regularly providing the service and also supervising and incentivizing the health extension workers can be mentioned as a key, as an area that shaped the delivery of primary health care in Ethiopia. Micah, if you have some additions, and we can also pass it to Dr. Humphrey if you want to add on this.
Yeah, I would love to hear, Humphrey, if you have any other broader reflections from across the region for some of those sort of software and intangible features that really work to underpin and strengthen primary healthcare systems as well.
Okay, yes, I think that's, I do, each country, even within a country, each region takes its own unique path. So I think one of the changes maybe which I should have brought on, it's more of a conceptual change, but it's very important on the ground, is that we're trying to move away from a prescriptive approach for PHC towards a more descriptive approach. So can we describe what a functioning system, for example, needs to look like? Can we describe what UHC needs to look like? And then within the country, within the region of the country, they are looking and saying, what is it that we need to do to move in that direction? So, for example, getting the issue of resilience, upgrading the issue of resilience to be one of the core descriptors of a functioning system, I think is a very important achievement. But then each country or each region within a country then needs to work out and say, what does it mean in my context? What does it mean for me to make sure that my system is resilient? I have these capacities. Is it about investing more in health workers? Is it about establishing more infrastructure and so on? So those kind of focus and discussions then take place at that level where they make the most sense. But then within all that, I think, and I think that question is quite interesting about the software. Within all that, there are certain software elements which we always need to think about. And if you look again, I think it was on slide 12 of what I had shown, I moved through it a bit fast. Within the system, we do recognize that there are a number of things. There's the organizational culture, there are the interests. I think that's a very important issue at all levels. How do you balance out different interests, the belief systems, how do people, what are the cultures and beliefs that are in practice, even among the service, the stewards, not just in the communities. how are the relationships within the team, the practices, and so on. There are a number of these soft elements which have a major influence around how outcomes need to be attained. And I think at present, our kind of recommendation is look at those software elements in the context of the hardware. So don't again get them and say these managers are corrupt, for example, or these managers are incompetent because they have come with a different organizational culture from what you're used to. Maybe there's something which they can add value to, but then it is not exactly in getting the right organizational culture. Maybe they have other skills and so on. They have very good oversight capacities and so it needs the software needs to be looked at in the context of the hardware that exists to be able to come out with a good system. But what we're insisting at this level is focus on the 4 capacities: access, quality, demand, and resilience. Whatever it is that's going on in the country, are you building those capacities? Are those 4 capacities moving up? And if they are not moving up, then there's a problem. If they are moving up, then I think then you seem to be moving in the right direction. What was the other question? I'm trying to check on the chat.
Yeah, so we have one that was upvoted a couple times, so maybe we can go to that one since we're also close to the end of our time, which is from Dr. Ahmed, and he's asking about, you had spoken, Dr. Humphrey, about working on resilience PHC in order to achieve UHC and health security goals. And so, a challenge here is the current structure for national health authorities. And so his question is really around the need to reform ministries of health, and if you have any advice for going about some of those reform processes.
Okay, reforming ministries of health. That is an first of all, if you're talking about resilience, there are a number of things that you can do at whatever level you are in the system. I think sometimes we always say, well, as long as the other people are not working, I cannot work. But I think, to me, it's more always an issue of have we done what we can do at our level before we look at the next level. Then, in addition to that, I think we've also been doing a lot of advocacy work. I think the Ministry of Health is as much a political structure as it is a technical structure. So it is not that just saying that this is the right thing that needs to be done, therefore it's going to be done that way. We need to look at it also in a wider political environment. And I think that's where many reform processes fail, because we usually just look at it and say, are you doing, this is what you need to do, and are you doing it or are you not doing it? Therefore you're performing or you're not performing. What you're calling a non-performing ministry might be performing in the eyes of the appointing authorities and so on. So I would recommend that a lot more of the emphasis that we're placing now is on, are we able, whatever level we are in the system, are we doing what we can do at that level? And then the lobbying and the push towards getting the appropriate managers in the ministry is something that continues in the background. It's not something which we say we cannot work until this has happened or until that has happened. I think that's the best I can do with that. The issue around reform of ministries is, ministries have been undergoing reform, I think, for the last 30 years, but we're still where we are with them. I think it's more an issue now as a manager, how well can I work with what I have? I've tried to talk a lot around that because it's quite a difficult question, but yeah. Okay. Is there another question?
Yeah, I think.
I said,
Oops. Go ahead, Dr. Andrew.
Sorry about that. Shall I proceed? We have a question from Magnum My question is, how can we sustain the attention given to health now, even after COVID, so that the health system will have enough financial and human resources to work on its inherent resilience?
I think that's a beautiful question, and I'll tie it a bit to Bakile Lamini's question from South Africa about are there additional reports on the performance and challenges of specific districts across Ethiopia. I think the attention span of many decision makers is only as good as when that issue is on the table. So the moment, at present, you know that there are 3 or 4 or 5 other issues fighting with COVID or with the health sector for attention in countries. And so we should, as much as possible, try to take advantage of the opportunity of being on the decision-making table. And one of the ways is to start to put a lot of this data on the table. For example, the performance data. If we're able to have subnational data in Ethiopia around performance of different subnational units vis-a-vis COVID or vis-a-vis their resilience, and we start to put that as part of the discussion at present, we should be able to mobilize a bit more attention, even as the attention on COVID starts being displaced by other issues. So I think it's about, can we generate additional issues beyond what we have at present? One of them is the performance. That is usually a very powerful thing whenever you're able to show subnational performance variations in a country. It's usually a very powerful way to get attention and keep the attention on the table. So I think we'll need to start playing with the different ways of keeping the spotlight on us now that it is on us, and we just need to generate this data. That to me would be one of the most powerful ways that we can keep their attention. If you're expecting the decision maker to always remember that health is important, I think we'll be asking a bit too much from them. Over.
Thank you, Dr. Humphrey, for the explanation. As we are coming close to ending our live session, we want to thank you for the nice presentation once again, and also the participants for asking very important questions. We wish we have more time to address those questions, but we promise we can have those questions and to be entertained during other live sessions and during the course delivery. So to you, Micah, if you have anything to say before we close this session.
Thank you, Dr. Antona. I also just want to say thank you so much to Humphrey and also to Aminata for joining us and for bringing these perspectives and being part of this really exciting course. So really appreciate you all, and looking forward to staying in touch as we all move forward with all of this important work.
Thank you. It was quite exciting.
Yes, thank you so much.
And if there are follow-up questions, please feel free to get in touch with us and we'll continue the discussion. It's an area which we can talk for the rest of the year. There are quite a number of exciting questions.
All right. Thank you all. Have a wonderful evening and day.
Thank you. Okay.
Bye-bye.